Let's get started. We're both super excited to be doing this, but first we just wanted to start with a little bit of our backgrounds. I'm Sam. I am a pelvic health physical therapist, which means that I'm a physical therapist, but that I specialize in the pelvic region and I address dysfunction of bowel, bladder, and sexual dysfunction. Basically I've been doing this for 3 years now, and my passion kind of lies in helping people achieve basic pelvic floor function again. These are needs of everyday life that people can struggle with, and I think really just kind of when I came out of PT school, I wanted to join the fight for especially women and female empowerment, but wanted to kind of join the fight for those of us who are kind of underserved in the pelvic floor areas. Yeah. And I'll send it back to Dana.
Hi, I'm Dana Shanis. I'm a board certified OBGYN. I do research with the National Institutes of Health on sexual health. And in the past year, I started my own private practice specializing in pelvic and sexual health, and as well as cancer survivor care. And basically, Sam and I work together a lot, but why I created this practice is that there really is a deficit in women understanding their pelvic floor, and unfortunately, actually in the OBGYN community, understanding the pelvic floor. So many women suffer from a lot of the issues we're going to talk about today, and even when bringing it up with their providers, don't really get relief. So hopefully you'll learn a little something today. We don't have a ton of time, and both Sam and I could talk about this topic for hours. So we're going to try to give you a real brief overview, but feel free to write questions and we can go into more detail about anything that you guys have questions about. So just to kind of start briefly, the pelvic floor is a basket of muscles that hangs off of the pelvic bone and basically has many layers that surround the bladder, the vagina, and the uterus, as well as the rectum. And so it basically is important in a lot of the functions that we're going to talk about today, but it's also part of the muscular core, which Sam's going to talk about it for a little bit.
Yeah, so I want to show my pelvic model. So here's the pelvis. The muscles that she's talking about lay right here at the bottom, and inside the pelvis lay your bladder, uterus, and rectum in the back. So if you think about the rest of your body kind of being on top of this, we have our intestines and our internal organs, and then right above it, above all those internal organs, is your diaphragm. And so if you think about your trunk, your pelvic floor, and your diaphragm, and then your abdominal muscles in the front and your back muscles in the back, your trunk is kind of like a soda can. And that soda can is what we traditionally think of as the core. A lot of times we think of the core as just our belly muscles, but really the core is all four of those things working together to stabilize your body. So from a physical therapy standpoint, we don't necessarily just look at the muscles of the pelvic floor. I will look at the way you breathe, the way you cough, the way your belly muscles are working with the way your pelvic floor muscles are working. I look at your back strength, your hip strength, your back range of motion, your hip range of motion. All of those things go into the mechanics of the way your body is functioning. And then I'll let Dana talk about what she looks at.
So the musculature is really important, but there are also tissue factors as well as neurologic factors that affect all of this functioning. And so when I'm doing the exam, in addition to looking at the muscles that Sam talked about, I also look for things like signs of nerve hyperactivity, which is typically done externally with something called a Q-tip test. I don't know if anyone has experienced that, but it's testing for areas where the nerves are overactive. Then typically I'll look internally at the vaginal tissue and look for if there's any dryness, any issues with the connective tissue that can kind of start to lose its elasticity with age, with certain medical conditions, with certain treatments. There are a lot of reasons why the connective tissue and the vaginal tissue can also be impaired. In addition, in my exam, I also check the uterus and ovaries just to make sure that there isn't any other pathology that could be contributing masses or endometriosis or things like that, that could also affect the function.
So then I want to just go over also what a physical therapy evaluation looks like. That's what a lot of people usually come in and say, I have no idea what you're about to do. So I want to go over what that would look like. So first, like I said, look at your breathing. I want to watch you move. How do you use your core muscles, range of motion, strength, things like that. But then the pelvic floor portion is a little bit different than a gyno exam, what we're kind of traditionally used to. I have you lay on your back. I get you underneath the sheet. I leave the room, let you undress from the waist down, and then you kind of come back and you're underneath the sheet. With gloves on, I'll lift the sheet up, and then I will feel the outside external musculature first. I'll ask you to Kegel, relax, contract, relax. We'll talk about what those things mean. And then with a lot of lube on my one finger, I will go inside the vaginal canal. Like Dana said, the pelvic floor consists of layers. So I orient myself to each layer of the pelvic floor via my knuckle. So the first part that goes inside is my first knuckle, and then the most that goes inside is my entire finger. And then when I'm all the way inside, if you see, I can really like lay my finger down on the musculature on the inside and feel for things like tone, tension, muscle knots. We get muscle knots there the same way that you would feel in your back. Or is it really kind of like weak and not active at all? And then with my finger all the way in, I can really feel your full strength and then your full relaxation of your Kegel. Yeah. And then I think we're going to go right into our next topic, right? We kind of have this split up. We're going to talk peeing, pooping, and sex. That's the way we're going to split this up. So we wanted to first talk about, go ahead.
Sorry to interrupt. I just saw a message that I think, so somebody just asked what causes muscle knots. And this is something we were going to go into a little bit later, but I think it's as good a time as any before we get into each of the function.
Yeah.
So there are various things that can cause it, but in general, inflammation is one of the key things that I look for. So when I'm examining and I feel those trigger points, often it is either inflammation locally, or really you can actually have increased inflammation anywhere on the body that can predispose you to having muscle spasms. And so that is something, that part of the evaluation is trying to figure out what is the underlying inflammatory process that is leading to that. So inflammation could be from something like endometriosis, which I had mentioned, and I'll talk a little bit more later. It could be from a previous injury. It could be from trauma. There are a lot of things that can cause that inflammation. And I see it typically does not affect fertility, although I don't know if that question meant endometriosis in particular, which is a topic for when we have a lot more time, but not the inflammation related to muscle spasms does not necessarily have a correlation with infertility.
Yeah, I was going to say the other thing that can cause muscle knots is back injuries, hip injuries. If you start to compensate in other ways for an injury kind of in the same pelvic area, and your pelvic floor starts doing more to compensate, that can cause muscle knots. If you think about, I always like to relate it to other regions of the body that we're a little bit more familiar with. So if you had a neck injury and then you start to hold your shoulder like this because your neck hurts, your neck might be filled with tension and tone, although that's not really where the injury was. So it's kind of like a little bit of a protection, but because you've compensated because there was a further injury. So that's another reason why there might be some sort of muscle knots in that area. Yeah.
So go on to peeing. Sorry to interrupt.
Head on to peeing, yeah. Okay, so first I just want to give a brief overview of what your pelvic floor should be doing when and what a Kegel is. We all kind of know what Kegels are and or I've heard of them, and I think a lot of people, when talking about the pelvic floor, the first thing that they talk about is Kegels. So a Kegel is a pelvic floor muscle contraction, and it's a squeeze and a lift of your pelvic floor. So a lot of women try to like more just kind of pick it up, but really there should be a squeeze and a lift component. Here is the thing that a lot of people don't realize is that you have to be able to relax from that Kegel. So you have to be able to squeeze and a lift and then a drop and open. If we relate the pelvic floor muscle contraction to another muscle contraction, like your biceps contraction, if you do a biceps contraction and you don't go all the way down, you're just doing bicep curls from here to here. So if you're doing Kegels and you're just going up, 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 which is I think what a lot of women try to do for strengthening, that is not full strengthening. We want full range of motion, all the way down, all the way up. And that's one of the biggest things I teach women how to do, is how to let go of those muscles so that we can pick them back up appropriately. So when it comes to, you have to be able to appropriately contract those muscles so that we don't leak and we don't pee when we don't want to. But then you also have to be able to appropriately relax those muscles to go to the bathroom. So we need to have voluntary control of those muscles. One of the biggest things that I want you guys to, we kind of talked about tidbits that we want you to leave here with this after this webinar, is how to prevent leakage when coughing, sneezing, or laughing for that matter, and also proper positioning on the toilet. So let's talk coughing, sneezing, and laughing first. When you cough, sneeze, or laugh, that's a massive increase in intra-abdominal pressure. There's a big buildup, a big in here. And you want to be able to kind of protect. So my rule of thumb is squeeze before you sneeze, and also cough, because there's no good rhyme for that. But it's squeeze before you sneeze and trying to lift and close everything. And then afterward, try to put everything back down so it doesn't stay there. And then proper positioning on the toilet for peeing. We will talk about proper positioning for pooping. Proper positioning for peeing is feet flat on the ground, forearms on your thighs, belly relaxed. So this is a great position to pee because you want your pelvic floor to relax. If you are squeezing your pelvic floor or trying to push it out, oftentimes you're trying to pee through a kinked hose, really. We want to be able to kind of go down and out and let your urine come out of you in a really passive, relaxed way. I think that's all I have to say about peeing.
Now, the other factors that I talked about, the tissue and the nerves, can play a role in urination as well, both being able to urinate freely and being able to prevent incontinence. So in cases where that connective tissue has really dropped, it kind of messes with one of the more functional aspects of our urinary system, which is initially when we're young, the urethra connects to the bladder at a very sharp curve. As the tissue drops over time, that angle changes, and that makes it so it takes less pressure. So it actually used to be a kinked hose when you're not trying to urinate, and over time that can kind of unkink. And so one of the things that we look for is why the tissue might be dropping. Things like prolapse can affect that, which is, unfortunately common. It can be the bladder, it can be the uterus, it can be the rectum. Also, lack of estrogen can decrease elasticity of the connective tissue as well as the urethral tissue, and that can affect that aspect of it. Another really big part of it is the bladder contraction. And the functional bladder contraction happens when the bladder is distended large enough to send a signal to the brain that it's full. And then in coordination with relaxation of the pelvic floor muscles, it will spasm. There are situations in conditions like painful bladder syndrome, or what includes interstitial cystitis, or overactive bladder, where inflammation to the bladder or nerve-related causes can cause that contraction to happen at times when it is not functional. And so that is a different kind of leaking that we see. That is typically urgency incontinence rather than stress, rather than with a cough or sneeze when you feel like, oh, I have to go right this minute or else I'm going to leak. That can be more of a bladder issue. So just briefly, because we don't have enough time to go through all these treatments in detail, one of the big things that we try to recommend is avoiding things that are going to irritate the bladder. So there's a whole long list of foods and drinks, and everything that's good is on that list, basically. But everyone responds differently to these irritants. So if you find that that aspect is an issue, doing a knockout diet or trying to avoid some of those more irritating factors might help avoid that part of the spasm. Bladder training is also something that's really helpful. Our bladder learns how large it can get by how large we get it. So one thing that I, all my friends and a lot of my patients do is I have what's called a surgeon's bladder. I used to do surgery for 8 hours on end and I wasn't able to go to the bathroom. So I can basically pee once a day. And that's not good for you. I'm not recommending it, but your bladder will learn to urinate when you tell it to. So bladder training is another important part of that. And then to deal with the tissue factors, things like vaginal estrogen or laser treatments are options, and prolapse, pessary could be an option, or surgery may be helpful in those situations. So I think we're gonna go on to pooping now.
Well, there's a couple questions. There was two, I just want to go back, yeah. There was a question that said, if I have leakage when I sneeze, can I get this fixed? Is that what I think you mean? Yes, you can fix that. I would recommend both telling your gyno that that's what's happening and then asking to see a pelvic floor physical therapist. Usually what is happening is that your pelvic floor and your diaphragm are doing something opposite from each other. And so you kind of have to retrain your body to get to activate your pelvic floor and use your pelvic floor effectively to close when you sneeze or cough. And then I'm gonna let you, Dana, take the next two questions.
Okay, hang on, I actually don't see them. Hang on.
I can read them to you.
What if you have a fallen bladder or I'd history? Okay. So I think that kind of is a similar question to another one about prolapse. So prolapse is basically dropping of different organs in the vaginal canal. And you can actually, after hysterectomy, which one of the questions addressed, you can have droppage of the vaginal vault where, even when you don't have a uterus or cervix anymore. So I could talk about this for hours as well, but basically, depending on which organ it is, if it's the bladder that's dropping, if it's a uterus from the top of the vagina, or if it's the rectum, it can affect things differently. This is more common in women who have had children before, if they have connective tissue disorders. And so, it is something that should be evaluated because in severe forms, it can actually lead to increased infections. It can lead to issues with urination, bowel movements, kind of all the things we're talking about, which I think just kind of, again, points to the benefit of seeing a PT and a OBGYN, because we want to make sure that none of these factors are surgical or have other causes, but you're gonna almost always have a muscular component as well. So, a lot of OBGYNs I know won't refer right out to PT, and I would ask for that because even if you had prolapse, you can still have some benefit from dealing with the muscular portion, even if the connective tissue, which is what happens in prolapse, is dropping those organs. So I do have patients that have even significant prolapse who with adequate physical therapy have been able to avoid surgery and stay functional, but it's something that needs evaluation by both a physical therapist and an OBGYN to make sure that nothing gets missed.
And then I think the other question was, what are the signs of prolapse? If you're feeling like something is falling out of you, if you're feeling any heaviness, pressure down in your vagina, if you feel the need to kind of push something back in or push something in to have a bowel movement, if you see anything coming out of you, those are typically the signs. And if you ask your gyno, there's a very quick test to look and see if anything is out of place or if it's moving where we don't want it to move. And then, yeah, like Dana said, ask for a pelvic floor PT in addition to other like management options, because we want to strengthen the muscles to kind of be the support from underneath. The pelvic floor is like your trampoline. And if you're coughing and your pelvic floor doesn't have the support, it's just jamming all of those down, right? You want to have the support from underneath. So when you cough, that it effectively provides a kind of shock absorbency from underneath for those muscles to not be kind of falling down. I hope we answered that. Okay, let's move on to pooping. Okay, so again, pooping needs contraction and relaxation of the pelvic floor. There's like, that's the very, very basics of it is that there's a whole lot that happens in your GI tract, but then your pelvic floor is what actually should accomplish the act of defecation. You need to be able to contract to hold stool in when you don't want it to come out, but then you also need to be effectively able to relax to let it out. So proper positioning on the toilet involves a squatty potty, and if that's another thing that you take away from this webinar, is go buy yourself a squatty potty. Everyone should have one. Hold on one second. Get my stool. So this is not a squatty potty, but it's just a stool that I'm using. If you can see right here, the way you want to sit on the toilet is knees up above your hips, feet flat, leaned forward. So getting your knees above your hips like that helps relax the muscle around your rectum, so that when you relax that tissue, when you can kind of get your hips above your knees, when you relax that tissue, your rectum isn't kinked and stool can just slide right out of it. That is very important as positioning, but if you do feel the need to give yourself a little bit of an extra push, we never want you to hold your breath and bear down. If anything, when you feel the need to push, you should try to exhale and blow your belly big and out. So if you're trying to push poop out, you should go and really expand your belly. And in that position, in that position with your knees up above your hips, it should happen very smoothly. And then I'm going to let Dana talk about the GI portion of it.
So in terms of gynecology causes for constipation and diarrhea, there is only a small overlap. So there's definitely a muscular component, but we do see issues with constipation and diarrhea with inflammatory conditions like endometriosis. So in general, if those symptoms are significant despite dealing with the muscular aspect after PT, then it may be valuable to get a GI evaluation to see if there's some other issue that could be like a inflammatory bowel condition or, another issue. What I do talk about is, again, avoiding irritants in the...
I think someone needs to mute themselves.
Yeah.
There we go.
Sorry. So I do talk about avoiding bowel irritants as well, and maintaining adequate hydration and fiber, because ultimately, if the stool is too hard, then it's going to be more difficult to pass the stool as well. But if you have significant issues despite physical therapy in this condition, in this area, I do think that a GI consult is not a bad idea.
Yeah. I'm going to take it back to the questions again really quick. So someone asked, is urinating and not completely voiding indicating a need for pelvic floor PT? And I would say definitely, but you should tell your gyno about it. So there is, like we've said, there's these medical sides of it and muscular components to both all peeing, pooping, and sex. And so your gyno should know. But I would, if they don't suggest pelvic floor PT, you should ask for pelvic floor PT. So I'm getting a little, there's a lot of questions coming in.
Yeah. So one other thing about that, one of the things that we look for, both with dribbling or incomplete voiding, is for masses around the urethra, as well as neurologic issues. So we, and this, I wouldn't assume that you have this if you're having that issue, but things like MS often present with urinating difficulties and things like that, or a urethral caruncle, which is like a little out pocket of the urethra, can kind of cause a dribbling or incomplete voiding. So definitely PT, I never think PT is a bad idea. But I just want to reiterate, for those issues, it is worth getting an exam by your gynecologist, and make sure you mention it to them, because they may not ask, so that they can assess for that.
I always ask my patients, I get a lot of patients who come from their primary care physicians, and I try to always ask my patients, when's the last time you saw your gynecologist? Like, we need to be working in conjunction with each other on these things, because I'm the musculoskeletal side of things, and there is this other component that we want to make sure is not the driver. And sometimes it is just a muscle issue, but we want to make sure that it's not these other things too. But yeah, the dribble pees, or sometimes having to force pee, like someone said in the chat, could be as simple as your inability to relax and open the musculature for peeing. So that's, yeah, what a PT will do is teach you how to do that, but we want to make sure that there's not these other kind of like scary signs as well. And then someone said she's bummed that we are 8 hours away. Yes, we're both in the Philadelphia area.
Yeah.
But I can, at the end, put a link to a website that you put in your zip code, and it shows you pelvic floor PTs in your area. That, I think that'll be really helpful for everyone.
Also, Sam and I both do telemedicine visits. So one thing that, I see patients from across the country via telemedicine, just because there aren't a ton of specialists who deal with these issues. So, you can also email us, and we can try to help get you connected with colleagues if we know of them. But if you need to talk to either of us, we can do that remotely as well.
Yeah, I do telehealth, but I find in person much more beneficial, because we really, I rely on really feeling musculature. So I would really, I think that seeing someone in person for PT at least is really, yeah. There is also a question about the yoni steam. Is that, do you see?
Okay, I can take that one.
Take that? Yeah. Yeah.
So it's interesting. There are a lot of procedures that are popping up to help with the vaginal tissue. And steaming, unfortunately, is one of the few that not only is not proven, but has some data showing it is actually unsafe. Because there's not standardization of how these steaming procedures are done, basically there are reports of burns that have occurred from it. And that is something, I don't think I need to tell you, that's not an area that you want to deal with a burn. It's very difficult, very uncomfortable to deal with a burn in that area. So, I have patients that have done it anyway and say that they get some benefit to the tissue, but I much prefer some of the safer options that have been studied that have very little risk to it. So, that's my opinion. Now, these things are new, and there are a lot of them popping up because they're big money. So we may find out in 10 years that certain versions of it are safe and done in a certain way by certain providers, which is one other thing that I, feel is important to say, that there are also a lot of vaginal spas popping up, and most of them are not run by gynecologists. And I have already had patients come to me who had complications from those vaginal spas, and their plastic surgery medical director or their family medicine medical director didn't know how to handle it correctly. So I would be very careful and find a gynecologist you trust to discuss these treatments, to make sure that if, even if it's not a high likelihood, but if something goes wrong, you really want to know who will be there to help take care of you. So just a little plug there. Be careful who you get your vaginal treatments from.
Yeah. And then there was one more quick one about peeing, which I want to address. It says, what if the pee seems to come out fine, but sometimes there's more in there, so when you flex a muscle, a bunch more will come out. So first of all, you definitely want to make sure that you're dropping and opening for the relaxation of it. But like Dana talked about, as we get older, there are a bunch of tissue changes. There's different angles happening of your urethra to your bladder. So that first position I talked about, where your forearms are on your thighs, pee all the way in this position, and then sit up and see what happens. Go to the side, see what happens. Go to the other side, see what happens. You can rock, I call it the rock and roll. You can kind of lean forward, lean back, try to get all of that out, because all these tissue changes can really impact the angle at which your bladder can really empty, but that can be really helpful. I wouldn't try to push pee out, but just see what happens by changing your position sitting on the toilet.
And that's something that is not uncommon with bladder droppage or bladder prolapse, because that kind of, as the normal relaxation problem happens, it can actually drop too far and kind of re-kink. And so as you're squeezing, you're kind of compensating for that droppage of the bladder. So that would be, you know, again, something to name, to mention to your gynecologist.
Yeah. Rule of thumb, if you've noticed, is you should mention all of these things to your gynecologist and ask for pelvic floor PT. But I did just put the link to, it's called pelvicrehab.com. Find a pelvic PT in your area. I put that in the chat. So if you are not anywhere close to Philadelphia, where the two of us are, you should find one there, or feel free to reach out. And we have colleagues kind of all over the country that we could probably send you to as well. So we're going to move on. I know someone just said something about each age group, which I think we could do maybe at the end when we're talking about the other. Yeah. We're going to move on to sex. Yeah. So just like everything else with the pelvic floor musculature, it requires both contraction and relaxation. The biggest thing that women tend to find when it comes to sex is that there's pain, or pain on insertion, or pain with deeper thrusting. That's usually what women come to us saying. The need for relaxation of your pelvic floor musculature as something is going inside is kind of like the biggest thing that I teach. Being able to relax that as something's going in. Often, if there is pain, we know pain is coming and we expect pain, so our body flinches in response. And how many times has someone in this group gone, okay, I'm ready, put it in, right? We want to be fully relaxed, in control of our pelvic floor musculature, so that you're opening and letting something go inside. Also, in terms of the contraction piece of it, when through the sexual response cycle with arousal and then to orgasm, your pelvic floor needs the ability to kind of involuntarily contract and relax. And orgasm is essentially kind of a rapid beating of the pelvic floor, but it's involuntary. So if you, again, with that bicep curl, are someone who is tight and there is not a ton of range of motion, you're going to have difficulty achieving an orgasm sometimes, and then also pain with an orgasm. An orgasm, if you have full range of motion, can be much more pleasurable, much more intense, and not painful. So that's often what I hear is kind of if someone even doesn't come into me for painful sex or sexual dysfunction, but yet then they start to have better sex. There's a lot of research that says that sexual function can increase with pelvic floor PT. Just a little plug there.
So I think, it's important to think about the whole sexual cycle. And, and certainly pain is one thing that we see with issues with the pelvic floor during sex. But what I often have patients come in and say is, now I actually have no libido and I don't get aroused, and I can't orgasm. And so it can be any of these steps that gets impaired that can kind of interrupt the cycle. And so while pain is one of the more common, that can lead to an issue with your libido, with arousal and orgasm. And some of that is through the constant muscle contraction, the lack of relaxation, but a lot of that is due to blood flow and the nerve irritation that happens with chronic spasm, that happens with issues of dryness, with certain medical conditions, and certainly the process of desire and arousal helps with the blood flow and the relaxation. So if you're kind of impaired in all of those areas, it's kind of like a snowball effect that you can end up really having issues during all aspects of sex. So a couple things, I would definitely see a pelvic floor physical therapist about painful sex, but a couple of things that we like to try. One, I can't say this enough, is masturbation. You know, when you have another partner involved in sexual activity, it changes the psychological dynamic. And that can really put a lot of pressure on you. And, you know, when you want to perform for somebody, but you're afraid that you're in pain, that just doubles the pressure, which is not good for sexual function. Masturbation, not necessarily to orgasm, but just for pleasure. What that does is it starts the hormone process working that leads to the increased blood flow and the passive relaxation. And I typically recommend, you know, especially if you're new with masturbation, to not involve penetration, to just have clitoral stimulation. Most women need clitoral stimulation to orgasm anyway, but it's about finding pleasure by yourself in a low stress environment. And if it ends in an orgasm, great. If it doesn't, that's still great. Taking that time will improve the arousal aspect of things later on. Another thing that we both, Sam and I both talk about a lot are dilators or a pelvic wand. And she's going to show them now. But basically, some of both the muscular tightness and as well as some of tissue tightness that can happen with lack of estrogen or some of these other issues can be helped with the dilators by actually stretching it out. So I often recommend as part of foreplay to use the vaginal dilators, or a wand is basically a curved, thinner device that you can get a little higher up in the vaginal canal. And that may help passively or actively relax muscles that we would have hoped eventually can passively relax. There's one other device that we don't have to show you right now, but if the issue is only during deep penetration that you feel pain, there's a great device called the O-Nut, which is a silicone ring that comes with 4 different rings that you can use as many or as few as you want. And it decreases the depth of penetration of a partner. And it doesn't interfere with their pleasure, although I'm not terribly concerned about that, but you know, most people are concerned about their partner's enjoyment as well. So, you know, I just want to make sure that you're not in pain. So the O-Nut, and we have that on our website, it's OHNUT, is a great device to look into if the pain's with deep penetration. But in terms of the other aspects, the libido, the arousal, and orgasm, there are other medical and minimally invasive treatments that can help with those. So that's another thing that I would definitely bring up to your gynecologist. And if they don't feel comfortable talking about these sexual topics, find a new gynecologist, because this is what we do. And, you know, and it's important to your identity, your sexuality, whatever that may be. And so you should not be embarrassed, and a provider should not be embarrassed to discuss this with you. So, you know, I think it's really important for you to advocate for yourself for these issues. Let's see.
Yeah. Other questions? Really quickly though, I wanted to talk about the dilators as well. So yes, they are really good to stretch. So this is one of the smaller ones. They start really the size of my like pinky, and then they get pretty large. This is the largest one, is size of yeah, that's pretty large. But this one, so I often like to start with something really small with my patients. So yes, it's really helpful for stretching tissue, but honestly, a big portion of what I use it for is training your body how to kind of undo the flinching response, to learn how to relax the tissue as something's going inside. So it's kind of a really good training tool as well. Yeah, just wanted to say that.
Yeah.
Then you can
so somebody just asked about what dilators are made of. There are thousands of companies that make dilators. Companies that I like are Intimate Rose, Soul Source. They use medical grade silicone, which is really important, that you want to get something that has a medical grade rating, because some of the ones that you can buy online are very porous and can hold some of the bacteria or soap and then end up irritating you. So I think investing in a good quality dilator set is a good idea.
Yeah, this entire set that I have has a set of 8, and it's It's like $170. It's pretty expensive. There is also another company that I like to use called hopeandher.com. They have a full set of 6 that is $45, but it's not medical grade silicone. It's actually medical grade plastic. But I have never had a patient who to have any sort of like difficulty or reaction to them. I will often recommend them if I think someone needs an entire set. I would, because it's only $45. That's the one that I usually go with. But there is, like there's a ton.
And most people don't need an entire set. What I usually recommend is figure out where we're starting from. So if you're able to insert a finger, if you're able to insert 2 fingers, or kind of try to figure out where you are right now. And the key is it shouldn't be painful if in your starting, or really at any point, it shouldn't be painful. If you cause yourself pain, you're actually going to be counterproductive in this process. So typically what I say is see where you're starting from and look at your partner or your toys or whatever it is that gets penetrated or gets inserted. And that's the range of what you might want. And so I have very few patients that get the whole set from the smallest to the largest. But you know, if you're starting at the beginning and your partner is that large, you might. But at a lot of the sites, you can pick which one, and they actually have the measurements, which aren't that helpful. You can kind of just eye it. But you can get maybe 3 or 4 that are in the middle rather than just, you know, getting a whole set or just getting 1 or 2. And just in terms of the website, on our website, the V Health and Wellness, under intimate health products, we have a couple of the sites that we like to use. So they're all listed there. And Sam, if there's any that you additionally want to add.
Yeah, hopeandher.com. I think that's.
And then the pelvic wand, Sam, do you have the pelvic wand to show them there?
For me.
So what's nice about the pelvic wand is the angle of it. The curve allows you to get some of the deeper tissues. So if the issue is not with initial penetration, if you are able to identify trigger points, and that company also makes a vibrating one, which is not meant to be, you know, like a vibrator for masturbation, although I guess you could use that. But just like, you know, a back massager, the vibration function can further help with the muscle spasms. So this is something that, you know, especially if you've been working with a PT or a gynecologist and you know how to identify your trigger points, this can be a really great option to use for that.
Yeah, the way this works basically is it goes inside and then kind of you use it on your muscle tissues. If anyone's ever seen those big Theracanes that you kind of work your own back muscle knots out, this is essentially a Theracane for your pelvic floor. Yeah. Someone said, how often would you recommend Kegels to strengthen the pelvic floor? So I'm gonna grab that one.
Yep.
There is no set recommendation. That is basically like asking how many bicep curls should I do to have good arm strength. It's not exactly as simple as that. So all these magazines and you know whatever pamphlets that we get that say do your Kegels are kind of BS. What you should do is try to keep good hip strength, hip mobility, lumbar range of motion, and core stability. And if you have no idea how to do any of those things, go see a pelvic floor physical therapist. But what you want, a true Kegel, like I talked about in the beginning, should have a squeeze and a lift, and then a down and an open, right? I sometimes even talk about it like it's like that arcade claw toy machine. You have to have a squeeze and a lift, and then a drop and an open. And if you are doing a full range of motion Kegel, that is great for strengthening, but that's just isolated strength. That's like just doing bicep curls. You don't go to the gym and just do bicep curls. You have to keep the entire area strong and mobile. So that is super important. I don't think ever really that just blanket Kegels are the answer for keeping a strong pelvic floor. The way to keep a strong pelvic floor is keeping strong hips, strong core, and breathe through those exercises.
Yeah, and one thing about Kegels also, though, is that this should be part of your lifelong fitness routine. As is, really core strength is something that's going to help prevent injuries later on. That is good for so many reasons. But, I get a lot of patients who are like, okay, well, I did it for a month. I felt better after confirming they were doing them correctly, but I felt better. So I stopped doing them. And guess what? The issues came back. So the key to this is that this is maintenance. This is not a get in shape quick and then just coast. This is something, so, I often say that once you know that you're doing them correctly, integrating them into certain activities in the day. And that can be true of other exercises too. If you're doing your stretching, if you're doing abdominal strength, whatever it may be. But so one thing, and I learned this, my mom's a doctor as well, and she taught me when I was very young, when you stop at a stoplight, you do your Kegels. And I live in the state, I don't drive that much, so I have to find other activities. But, it is something that I would try to, once you learn how to do them correctly and know what things you need to work on, integrate as an ongoing part of your overall health. And that's the best way to maintain the benefit that you get from the exercises.
Right. I personally start every workout with 10 just up and down, just to kind of get those pelvic floor muscles moving, get them mobile. But I think it's super important that if you're someone, you have weak hips, you have a weak core, you are not going to be able to just do Kegels and have that fix all of the problems that you're experiencing. So that's important. But if you know that you're doing them correctly, you know that you're keeping a strong core, you know that you're a strong person, every stoplight, pick it up, put it down, pick it up, put it down, pick it up, put it down. All right. Oh yeah. And someone says a friend does them when brushing your teeth. Perfect.
Great. Yeah. Great. And that's actually, I think it's a great analogy to brushing your teeth. It's not like you brush your teeth one day and then suddenly your dental health is fine forever. You brush hopefully twice a day, every day. And that, needs to happen with your muscular strength as well.
Right.
Great. So should we go on to, and you guys have such great questions. Hopefully we aren't keeping you too long. But what we wanted to talk about last was chronic pelvic pain, which unfortunately is a really, really common issue. 1 in 5 women actually are suffering from chronic pelvic pain. And so there are a couple of conditions that you may have heard of. Endometriosis, which I'll just briefly say is tissue similar to that of the lining of the uterus, but elsewhere in the body. And we estimate that 1 in 10 women have endometriosis, but really I actually think it's much higher. We just have poor ways of diagnosing it. But endometriosis can cause inflammation, muscle pain, lots of issues. So that's something to know about and ask about if you think you might have symptoms. Painful bladder syndrome, which includes interstitial cystitis, has a lot of issues with bladder function, and that is considered a chronic pelvic pain condition. Pudendal neuralgia is another one, that the nerves in the pelvic floor are inflamed, and this can cause issues with sitting, vulvar pain, lots of different issues with that. Vulvodynia is another one where the nerves in the vulva cause constant irritation, itching, burning sensation, and a lot of women think they have yeast infections that go, that just keep coming back, but often it is actually a neurologic issue, and we call that vulvodynia. And then there are a lot of muscular components, which I'll let Sam talk about, that can lead to chronic pelvic pain.
Yeah, so basically the diagnoses that Dana just went over, there's usually a driver kind of ahead of the muscular component, and then the muscles are responding to the pain and thus becomes dysfunction. So as a pelvic floor PT, if someone says I have endometriosis or I have interstitial cystitis, I'm not going to be treating and trying to cure that diagnosis. I'm going to be trying to manage the symptoms that go along with it. So basically what happens when you're in pain, the pelvic floor, like any other muscle group really, can guard up and try to protect itself. And you can sometimes find yourself, a lot of women who have been battling, say, endometriosis for years come in a constant state of contraction and they have no idea. But it's basically that their body is just protecting against pain all the time. It goes back to the same neck analogy. If your neck's in pain, you're going to kind of guard yourself against that and hold your shoulder in a way that then leads to problems with your shoulder. So a lot of women end up kind of in my room because the endometriosis for years has now led to painful sex or difficulty with peeing. And then that's the functional part that we'll work on. But we kind of have to work on the response to pain and help at least reduce some of the nervous system activity that happens with that, that muscular component. And that involves a lot of stretching, flexibility work. I will often do a lot of trigger point work inside, the same way that a PT would work on the knots in your back. I would work on the knots inside and then make sure that you can kind of appropriately lengthen the tissue that's been so up and guarded for so long.
And in addition to that, even it's again another cycle, because this initial inflammatory process leads to the muscle spasm and the pain, but it also leads to something that we call sensitization. And this is a process that can cause women to actually have pain all over their body, regardless of where the initial inflammation is. And what this process is, so basically when we're born, our brain tells our local nerves to ignore painful stimuli that they don't believe are causing injury. It's why we're able to lean on our elbow and not feel like our elbow is getting crushed. Why we don't, respond so strongly to every stimulus is our brain tells our body, you are not being injured, so you're not going to think of that stimulus as painful. When the body has chronic inflammation, what will happen is that process says, well, I am being injured all the time, so I'm going to stop telling you that you're not being injured. And so what we find that the longer that these inflammatory processes go on, the longer that the muscle spasms are there, the more our nerves get used to being in pain. And then even if you take away the pain, often it stays there. And so there are women who, many of you may know women who had endometriosis, they had a hysterectomy, and they're still in pain. And they say, well, I don't have any female organs. Well, endometriosis can be anywhere, but some of that is the nerve inflammation that never got to heal. And so when we're dealing with the pelvic floor, which is one of the common drivers of this sensitization, if you don't deal with the nerve reaction to it, then it's going to be much harder to get comfortable. And there are a lot of things that we can do, which, I don't really think we have time to go through all of that. Maybe we'll do another talk on just that. But that is something to talk with a pelvic pain specialist about. Most OBGYNs are not trained in dealing with chronic pain sensitization. So that's something, that is important to keep in mind. And along the lines of that, there's another thing that I think is important to talk about when we talk about anything with the pelvic floor, and that's mental health. Depression, anxiety, issues with your neurotransmitters are going to greatly affect your perception of pain. It's going to affect muscle spasms. And I think Sam and I both believe, even though we don't have great evidence, that trauma can be held in certain muscles in our body. And the pelvic floor is a really common one. So we see a disproportionate number of sexual trauma patients and injuries too. That's trauma as well. But also psychological trauma. So I think that any talk about pelvic floor health has to include being aware of your mental health. And I don't know anyone who is not anxious now. This is just a crazy time. But even not with the pandemic, there's always stress, there's always things going on. Depression and anxiety are extremely common. And so that's something that I think plays an intimate role in your function of all of your pelvic floor issues. So that's another thing that I would bring up. If you don't get asked about it, mention it. And if your provider's like, you're fine, just have a glass of wine, look for another provider, or tell them, no, I think that this is affecting my health. So, I just always try to make a plug for that your mental health is a huge part of your physical health. And I think it's worth taking some time to address that.
Yeah. So that's really all we have for you guys today. This was obviously a very, very brief overview of a very complicated topic, and we could go on and talk at each little thing forever. We could have little classes on peeing, pooping, sex, pelvic pain. We could do it all. So if you have more direct questions, our information is in the chat. You can feel free to email us and ask us more specific questions. If you want to stay on and ask questions anonymously, you're more than welcome to private message us in the chat. One person I just really wanted to address this that had asked for kind of like tidbits in each age group, because it does look like we have a wide age range. So in terms of pelvic floor muscle health, when the younger you are, the better it is to kind of get familiar with your pelvic floor. As we get older, there's a lot of stuff that changes, and it's harder and harder to connect with some of those things. So if you're a young woman and you do plan on having children, even if you don't plan on having children, like I said, because it makes your sex life amazing. So even if you don't plan on having children, but if you do plan on having children, it's really, really great to get in touch with those muscles, because having children really does a number on those muscles, even if you have a C-section, which I like to call a belly birth, because your abdominal muscles are cut through, and like with that trunk support, if your belly muscles are cut through, your pelvic floor and your diaphragm are impacted as well. So any woman that has a baby leave their body in any capacity should have pelvic floor rehab. And then in terms of kind of middle age and older, these things happen. These things occur with body changes, tissue changes. And if you're experiencing any sort of dysfunction, if you take anything away from this, I hope that you advocate for yourself when you go to your gynecologist and say, I would like to see someone. It's not enough that we get referrals from physicians. I think gynecologists are now really sending people to pelvic floor PT, but even if you mention it to your primary care physician, say to them, I want to go to PT, and they will more often than not write you a script. And there's a lot of PTs also who don't even need a script, but that's a whole other talk. But I think those are like kind of the different age groups, if you want to touch on those two.
So I'd like to kind of start even earlier. So I think that many young girls have issues with their pelvic floor that don't get recognized. I think endometriosis is underdiagnosed in teens and young girls. A lot of them just are told periods are supposed to be painful. A lot of young girls have injuries in sports. And I think that a lot of young girls learn dysfunctional bowel habits, I think most girls are told that sex is going to be painful initially. I think that if you have a daughter, I would start addressing these issues with puberty, and maybe even before puberty, talking about good bowel and urinary habits. But I think recognition of the pelvic floor issues early, a lot of the patients I see a ton of 19, 20-year-olds who really have been having pain for 8-10 years. And unfortunately, the longer you're in pain, the longer it takes to unravel that pain. And so, women who have been in pain for 10 years come in, and I tell them, you're not going to feel better tomorrow. If we can get you getting a little bit better, it could take you years to feel back to normal. And I'm not saying that to be depressing. I just want to be realistic. So I think the sooner that we intervene on these issues, the better. And there are some studies showing that incontinence issues, pain with sex, really happen in their 20s frequently as well. So of course, as you get older, we find that these things are more common. But I think one of the problems is the stigma that, a lot of my young patients will say, well, I haven't had a kid and I'm not menopausal, so I assumed like I should not have this issue. And nobody should have this issue, but it happens to women of all ages. So I think that being mindful of things that cause pain, looking for issues with urination, with bowel movements, with sex, with pain, painful periods. All of these are things that at any age you should discuss. As you get older, then the value of looking for tissue factors goes up a little bit more, but there are some young women, even without connective tissue disorders, that get prolapse at a young age. So, it is something that I think really, no matter how old you are or how young you are, you really need to be aware of all of these things.
Yeah.
Let's see.
There was
Any other?
2 more questions. Yeah, one question said, I'm 14 weeks pregnant. How soon should I ask for a referral for pelvic PT consult? I personally, now, but I personally, just as like a personal rule, I wait to see patients into the 2nd trimester. And so if you're in your 2nd trimester, get it. Right. I also, if you are pregnant, I love to teach my pregnant patients how to push a baby out. That is something that when you have birthing classes, they tell you everything about labor and delivery, but they don't teach you how to actually use your pelvic floor effectively. And that's something that I really, really like to do. There's a lot of good research coming out nowadays that it says that if you go to pelvic floor rehab before and learn these muscle mechanics, then afterward your outcomes will be and rehab will be much easier, but also that it can really reduce injury during delivery itself. So yeah, definitely see one now.
So first of all, congratulations. And now that you are in your 2nd trimester, I actually never think it's too early. I have some patients that even during preconception counseling, I recommend that they get into physical therapy. And part of the reason is that the dynamics of your core change over pregnancy. And so back pain is really common. Incontinence is really common. And some of these things may not be overcomeable. If your baby kicks your bladder, the best Kegel might not be enough in that one situation to hold the urine back. But good core strength and awareness of the pelvic floor and your core can cut down on back pain in pregnancy. So I, as an OBGYN, have never told a patient, don't go to PT now. In the 1st trimester, a lot of women don't feel great and aren't doing as much activity. And so, I think it's fine if in the 1st trimester they don't necessarily, start. But I actually say start now. Any woman who wants to do pelvic floor PT for any reason, it can only help if you have a good pelvic floor physical therapist.
Yeah, it says, is there a specific condition that I can ask a referral for? If you have a good physical therapist, they will be able to make it covered by insurance. Is kind of what I'm saying.
Maybe just mention a couple of the common ones.
Back pain, pelvic pain, hip pain. Anything in that regard. I usually write it in my documentation for the insurance as that it's pregnancy-related back pain due to progressing pregnancy. And I haven't had an issue ever with insurance not covering that so far, at least.
And diagnoses like incontinence often will get covered. There are a range. So, I think all of us can figure out, something that is not ideal that the provider could put as a diagnosis code.
I've had plenty of patients come with a script that says back pain, and technically I am treating the lumbopelvic area. And so I often will, even though the script says back pain, I write in my notes that I'm working on internal lumbopelvic stabilizer musculature. It all is the same. And so as long as I document appropriately, it should be totally fine. Someone said burning with a bowel movement. What about burning with a bowel movement? Do you want to tackle that one?
Sure. So what we worry about with burning, that's usually a nerve hyperirritation issue. So it could be from muscle spasm and the muscles being pushed. It feels like burning. It also could be a skin issue. So you could have fissures. You could have perianal yeast infections are actually very common. You could have hemorrhoids. So that is something, if that's consistent, and especially if you have any bleeding, it would be something, and an OBGYN can evaluate the perianal area. You don't necessarily have to go to a colorectal specialist, but it's something that I would have them examine. But muscular issues also can cause that burning pain. So one of the things that we actually can do for women like that have that issue is rectal diazepam, which diazepam is just Valium, you know, an anti-anxiety medication, but that can relax the nerves and the muscles if it's really painful with bowel movements. But before you do that, you definitely want to make sure that there isn't some kind of tissue or structural issue that could be causing it.
And then someone said, I hurt my back years ago. My chiropractor said it was mainly the iliopsoas. Then I had a baby. I noticed the incomplete voiding with urination. Good to see a pelvic PT now. Yes. Tell your gyno that that's what's happening, and then absolutely go see a pelvic PT, pelvic floor PT now. Yes. Never. It's never too late. You're always postpartum. It's never like you're not postpartum, right? It's never too late. Go now. All right.
All right, and I see, so there's a question about fibromyalgia. It says fiber, but I see fibromyalgia. So what fibromyalgia is on the same, in the same category as these chronic pelvic pain disorders. And we think it has a lot to do with sensitization. So what I would say for the person who wrote that question is that I think that there is, you know, fibromyalgia is a complicated condition, but often a combination of desensitization techniques locally where you're having the symptoms, but then also antidepressants that can help reset the neurotransmitters seem to be a combination that can be helpful in patients with fibromyalgia. But basically that's the sensitization where, you know, pain testing on women with fibromyalgia show increased pain everywhere, no matter where the symptoms may have started. And so there's a lot of overlap with that and chronic pelvic pain.
So the person who just asked about pelvic floor PT in Canada, check that website that I put. I can put it again, pelvic rehab. Oh, no, that's the wrong person. pelvicrehab.com. And you should be able to put, I'm pretty sure Canada will be on that website. You just put in your zip code or put in where you live and it should tell you. I don't know anything though about pelvic floor physical therapy and insurances in Canada though. I don't, and so you're gonna have to kind of talk to how that works up there.
So I see a question about pelvic floor pain and pain around the tailbone. So your pelvic floor muscles actually connect to your tailbone, to your coccyx. So it is extremely common if you're having issues with spasms for it to include the tailbone. So it may just be the location of where your symptoms are worse, but that still very much could be the same pelvic floor spasms that we've been talking about. All right.
And then someone said, I've been to pelvic PT for 2 months and have had no relief. Number one, I would make sure that your gyno is appropriately in this care team, and is there anything that the PT is missing? Number two, sometimes you don't gel with the pelvic floor PT and you might have to find another one. But yeah, your gyno should definitely be part of the care team.
Yeah, unfortunately, I think there's a lot of variation in the training. And so that's something I feel very lucky to have Sam. I know that she's very good, but I have had patients who have gone to PTs, pelvic floor PTs, even for like a year, did not relief, and then they go to one that might understand a little more about the complexities, or maybe it's just the right fit for them. You know, it may not be that they're a bad PT, but what they specialize in or their strengths may not be exactly what you have going on. But in general, another thing that I say in my patients who have gone to PT and not gotten improvement, that is definitely an indication to find a pelvic floor, a doctor who is a pelvic floor specialist, a pelvic pain specialist, but that's also a time that you might need imaging or, you know, an additional workup to make sure that it isn't one of the rarer causes. Because typically, you know, if done well, most people are going to get some benefit from the muscular portion of the rehab. So, you know, I think that's something, 2 months, maybe you need a longer, maybe you need another PT, but also to talk to somebody who specializes in this to see if you need imaging or an additional workup.
Awesome.
Any other questions? You guys were great. These were really great questions. A lot of fun.
This was awesome. But like we said before, if you have questions that you think of later, please feel free to email both of us or one of us or whatever. We'd love to keep in touch with all of you and tell your friends everything.
Yeah.